Good evening, everybody, and welcome to another conversation with a doc. And we're so pleased that Dr. Justin Martello is here, and he's going to be talking about new therapy updates. And I don't have another thing to say except I'm really looking forward to this, and I hope all of you are too. Remember, please to fill out the evaluation form that we're going to send at the end of this. It's really important that we get some evaluations from people. And with that, I'm going to introduce Dr. Martello. Take it away.
Thank you, Judy. And so thank you for everyone for having me listening. Today we're talking about kind of updates. This should actually say probably 2024/25 therapy updates. And I specifically wrote therapy because we're not going to just talk about medications. We're going to talk about other kind of interesting and cool things in the Parkinson space that is out. And then we're going to finish with things coming out. Just a quick disclosure side. So I am a paid speaker for all the three companies with new medications this year, but I haven't given any paid talks for any of those medications, but for other things for the company. So like I said, we're going to go take a step back, talk about just really quickly about Parkinson's progression and gaps in therapy and why not only are these new therapies really exciting, but also it's really an exciting time to be in the Parkinson's kind of space for research and new developments, especially now that we're coming out and distant past of the pandemic. Research is definitely going full steam ahead. So we'll talk about that. We'll talk about what those updates in PD therapeutics are, kind of future of PD, and then we'll finish off with should have plenty of time for question and answers. I know there's a lot of questions that were already submitted. As Judy said, if you have any further questions, definitely put them in the chat for me to answer at the end. So just to kind of show you a sense of, Parkinson's progression over time, and just to orient you to this slide. So the x-axis kind of going across is time, and I'll talk about that in a second. And then the y-axis is degree of disability or kind of severity of symptoms. And you can see kind of in the middle, usually when you talk about a graph like this, you're talking about time zero being all the way to the left, right? But time zero is in the middle, because with this disease, as with many other diseases, we do understand that while we talk about when does the when does the disease start, right? When did your physical symptoms, when did the obvious symptoms start, like tremor or slowness of movements, stiffness, weakness, decreased arm swing, difficulty getting up from a chair? When did those physical symptoms start? That's when your disease started. It's actually a misnomer, right? It's actually not the case. That really the disease has been going on for sometimes decades before the actual disease is actually diagnosed or caught by the patient, caregiver, and providers or clinicians. And so that's why time zero is in the middle. Anything before time zero is what we call the premotor or prodromal phase of the disease. And this, just to mention the main symptoms that people can get leading up to Parkinson's or as a sign of Parkinson's. Well, the most probably non-specific symptom is constipation. That can come from a lot of different reasons, but some of the more specific symptoms would be RBD or REM sleep behavioral disorder. That's kind of when you punch and kick in your dreams, thrash around in your dreams, many times without knowing it. And then a loss or decreased sense of smell is a big one too, that leads up to the diagnosis. And some people will say, oh, I lost my sense of smell years ago, or I had that issue with sleep for most of my life, right? Well, it's true for some people. They can have Parkinson's for, again, decades before it becomes more obvious. The reason I like to show this slide as far as gaps in care is because while we're going to talk about a lot of cool new things coming out or that have been approved, we still do not have any what we call disease modifying medications, right? There's still nothing that, as far as a medication, can slow down the disease or stop the disease or cure the disease. That is still really just exercise that we talk about as far as the only thing that can slow down the disease. So, and the reason, again, I show this slide is to say that by the time we catch it, or quote unquote, catch it or diagnose Parkinson's, the damage is done, at least up to a certain point in your brain already. And so we're really trying to focus research in capturing these early patients before they show the physical signs that are more obvious signs of Parkinson's, and really starting some kind of treatment back then, so we can slow it down or stop progression before it starts. Now, there are still medications after you develop symptoms, because we do understand, yes, okay, maybe some damage is done, but not all the damage, and not even maybe most of it. And so maybe we can still slow it down even after you show symptoms. Then obviously, we talk about usually a linear course of symptom development, meaning this kind of steady progression of symptom worsening over time. But some people can say, I don't understand. I was slowly progressive, or not that really rapidly progressive, for many years, and then all of a sudden, the past year or two, things have been snowballing out of control. And you can see, because other things start to happen that builds on the motor symptoms, right? So you have kind of bottom, lower, light gray areas, the non-motor symptoms. So fatigue is a big issue that comes into play in this disease. Urinary symptoms, blood pressure, dementia, sometimes pain. And then you have the motor symptoms that are gradually worsening, and they can evolve eventually walking issues, balance issues. And then on top of all that, you have what we call motor fluctuations. And we'll talk about that in the next slide, combined with possible psychosis down the line. And so when a lot of these issues start to kind of compile on themselves, it can seem like you are more rapidly progressive. It's just more of a case that we need to start tackling and treating these different types of issues, so that things can kind of quote unquote slow down again, and so you feel better. But until that happens, it can seem like you're spiraling out of control. So one of the big kind of gaps when the disease starts to get in what we call the advanced stage, where you're not severe, you're not end stage, but the medicine, the dopamine levels are really not consistent throughout the day. And so you have what's called motor fluctuations. That's what a lot of these medications are based off of. And so I like to define it before we talk about things like that. So this is really orient you. The x-axis is time. This is kind of over a day, okay? And the y-axis is your brain dopamine levels. And so we think about dopamine levels being mostly driven by carbidopa levodopa, the mainstay therapy of Parkinson's disease. And it's still the mainstay of therapy because it works in the most natural way. If I took it, you take it, our bodies convert it directly to dopamine. And so essentially it's just dopamine replacement therapy. And so, yes, there's plenty of other medications that raise dopamine levels, but let's just imagine that someone's on carbidopa levodopa 3 times a day. You see this spike in dopamine levels, and yes, it's different for different medications. And then, so the medicine gets absorbed, your dopamine levels go up, right? This kind of white line goes up in your system, and then your body kind of uses it up, right? Processes it, and then it goes out of your system, and then you take the next dose, and it goes up and down, right? Anything within this kind of teal area is where, if the dopamine levels lands there, it's really treating your physical symptoms great. A lot of people kind of forget, or will say, hey, I don't know what you mean by, when I'm on or off the medicine, like I don't really feel a difference throughout the day. I don't feel this roller coaster ride. In many ways, that's good, right? You shouldn't feel that, right? Your body wants to see dopamine throughout the day and really help control your symptoms. And a lot of patients will say, well, what do you mean control my symptoms? Like, I don't even remember why I'm taking this medicine. That's where you have to talk to your neurologist and go back and say, all right, we started the medicine, it may have been years ago. What really helped back then, and what are we seeing now, right? For many people, it's, oh yeah, it really helped my tremor, or I felt stronger. I felt like I can move around better. My walking was better, or I felt less fatigue. It's different for everyone. And so you have to go back and first understand, why are you taking these medicines, the Parkinson's medicine? What physical symptom is it helping? Because usually we're talking about the physical motor symptoms that it's helping, not really the non-motor symptoms, which it can sometimes help with, but usually we're sticking with the motor. So once you have a better understanding of that, we can now fast forward to say, okay, what's going to happen eventually over time? And when we say eventually, usually we mean like anywhere between the 5 to 7 year range for most people, will start to develop this kind of roller coaster ride where, as you can see in this picture with moderate disease and then advanced disease, what happens is this, what we call this therapeutic range, this range of dopamine levels that really help your symptoms without causing any problems, it starts to narrow to the point where if your dopamine levels get too high, then you start developing dyskinesia. So that's like kind of the writhing motions, wriggly, kind of anxious movements, kind of body rocking, not the rhythmical motions that you see with tremor, which a lot of people confuse. Tremor is rhythmical, right? Usually of your hands, sometimes of your legs, your chin. Dyskinesia is more of a flowy, kind of irregular movement, different parts of your body. Some people are just their head, some people they're just their hand or their foot. That's what we call dyskinesia. And then anything below that area, that teal area, that therapeutic area, that's where the medicine's not working. So a lot of people will start saying, yeah, I feel like my medicine kind of wears off, a half hour before my next dose is due. I start feeling maybe a little bit breakthrough tremor, or I feel just a little bit more run down. I take my next dose, I feel better again, right? And then sometimes it can take a little while. So I'll ask patients, well, when do your medicine wear off? Say they take it every 4 hours, right? They might say, oh, it wears off around 3.5 hours. Okay. So you take that medicine at 4 hours. How long does it take to kick in? Because that's a whole wearing off, right? It doesn't just kick in like that. A lot of times there is a delay of half hour, 45 minutes, 60 minutes of delay action. So you have a total of an hour and a half of off time between doses where the medicine is not working optimally, right? And so this, again, just gradually gets worse over time. A lot of people worry that motor fluctuations happen based off when you start carbidopa levodopa or the dosage or what other medicines you're using. We know, and as an author of the most recent guidelines about this in 2021, we know that for a long time we've known this, that really the risk of this happening, this kind of motor fluctuation, kind of roller coaster ride, is dependent on really two main factors. One is the time that you've had the disease. So not the time that you've started medicine, the time you've had the disease, which you can't control, right? And then the other factor is how much total daily dose of levodopa, because we do know that high doses, like over 10 pills of the yellow pills or 1,000 milligrams of levodopa and higher, can really start to make that risk higher. Now, I do have some people who do need that much, who do need really high doses because for whatever reason, their absorption in their stomach or the way that it gets brought to their brain or the way that their brain is making or not making dopamine, they just need higher doses, right? So that does happen. And so it's not a limit, but that's kind of one of the things that we try to avoid. And the good news is, and we'll talk about it today, we have a lot of ways to avoid really high doses of levodopa with what we call adjunctive medicines, kind of helper medicines to help the levodopa, long-acting versions of levodopa, other delivery systems for levodopa, which we'll be talking about today. But it's really how do we keep the dopamine levels within this therapeutic dose and not have this kind of up and down kind of roller coaster ride throughout the day, which a lot of oral medications tend to do. Other medications tend to do this too. And so we're trying to find get the dopamine levels as steady as we can. What we normal or affected people, sorry, people who do not have Parkinson's disease, we tend to produce and deliver a steady amount of dopamine throughout the whole day, right? It doesn't change no matter what you're doing, and so we're trying to mimic that steady kind of delivery of dopamine in the most efficient way, and that's where these new therapeutics are starting to come up. So this slide just kind of represents everything that we have now, minus the new things I'm going to talk about. So even right now, again, minus the new things, we do have a lot of options, which is good. That's the other thing that I usually tell patients is don't worry about, using up the medicine. That's not how it works, right? Just because you started the medicine, 15 years ago doesn't mean that it's not going to still work. It's really more about the disease progression. I should have mentioned that before, but that's why we've kind of taken an opposite approach than what kind of prior generations did, where they kind of saved and reserved the medicine till you really, really, really needed it. Now we kind of take the opposite approach because, listen, today, at this very minute, your brain has the most and the most healthiest dopamine receptors that it will ever have, right? But it just doesn't have the dopamine to respond to. So just like any other vitamin, because dopamine is a vitamin,
Oh,
it's a
I didn't know.
neurotransmitter, but same idea. If I told you, you were low in B12, you wouldn't say, I'm going to hold off taking B12 until I really, really need it down the road. You're going to take it right now because it's just about levels, right? You get your levels up, you keep them up, done. Same thing with dopamine, right? You're going to take the dopamine, get your levels up, and keep them up until your disease worsens and that therapeutic range starts changing, and then you need to adjust what you're taking. And so, I usually say these classes of medicines are not other types of classes that you hear about all the time where your body gets used to them and they don't work anymore. That is not how dopamine medicines in Parkinson's work. So again, this is kind of all the different categories of medications. We're not going to get into all the ones that exist, just giving you a sense that there are a lot of options even now to treat your motor symptoms. But there's still a gap. There's still patients who try lots of these medicines. They either have side effects or they don't work, or they're taking other medications that make it that they can't take some of these things. And so we still have that need for when patients really get to advanced disease, they get motor fluctuations. How do we better control them at that point? This is kind of just illustrating that we actually do very well when it comes to research in Parkinson's. Parkinson's disease is the second most funded research or neurological disease that's being researched right now. It has the most funds going in it behind Alzheimer's dementia. And so there's a lot of money going into it. Last year, there was the Parkinson's declaration to put even more money and more efforts into Parkinson's disease from a governmental perspective. And so, I think we're in line for success. Unfortunately, we've had this gap of the pandemic of the past 4 years or 5 years where research slowed down. But the exciting thing is, like I said before, it is ramping up to pre-pandemic levels. For sure, companies are actually doing things a lot smarter. Both pharmaceutical companies, governmental companies are doing a lot of things smarter to make research more efficient and more useful. And so, kind of starting from August 2024, I'm going to illustrate the 3 new medications that have come out, some other therapeutics that have come out too since then. But I'm going to just do it kind of in order of when they came out. So, Crexont, which is the brand name of carbidopa-levodopa extended release. Some of you may be saying, well, I already thought there was an extended release, and that's true. We'll talk about the differences, but it was FDA approved in August 2024. It is a long-acting carbidopa-levodopa, so there's nothing new about the medicine in this capsule, but we'll talk about what makes it different from prior long-acting carbidopa-levodopas. It is kind of FDA approved to work between 6 to 12 hours. Now, I put in parentheses 4 to 6 hours because there's a difference, obviously, between in the research studies and in real world practice. And I think when this medicine came out, we had a lot of patients who were desperate. We were desperate that we needed something better to control their day, especially in a more advanced case. And so you had, especially in the beginning, a lot of advanced patients who really wanted something that worked longer than 2 to 3 hours, right, with their immediate release, the yellow tabs, the carbidopa-levodopa. And so we would start them and we would quickly find out, yes, it is definitely a longer acting medicine, and it was compared, I'll show in the next slide, to both Rytary and to carbidopa-levodopa immediate release or Sinemet. And it does work better, but it wasn't the pristine, optimal kind of case where maybe you have a younger patient where, hey, maybe we can get 12 hours out of this or 8 hours or whatever, which is better than what they're getting. So Crexont was or is created by this company Amneal. Amneal also creates Rytary. Rytary is also extended release carbidopa-levodopa. When they released it, and still is the case, the company is kind of dedicated that because this is similar but not the same as Rytary, and that this is kind of an improved version, that they kind of committed themselves to making this price of this new brand name medicine at least the same or less than the Rytary. Now, as far as data behind this, uh, before we get to data, so the kind of the new technology that is how Crexont works differently than Rytary and both Cinemat and the old kind of carbidopa levodopa controlled release is that it has this new mucoadhesive polymer, which allows the medicine, which is kind of micro kind of bubbles or micro capsules of extended release and immediate release carbidopa levodopa, to adhere to the jejunum or the small intestine of the body. That is the place in the body that we think absorbs carbidopa levodopa the most efficiently and brings it to the brain most efficiently. So it really needs to get past the stomach, past the duodenum, into the jejunum in order to really act and absorb correctly. So this is a new technology. Rytary doesn't have this, Cinemat doesn't have this, but it allows it to be released at the area of your body where it should be. So as far as the kind of pivotal trial data where the FDA approved this medicine, so you can see, again, x-axis is time over weeks, y-axis is time over hours, and we're looking at, in this slide, good on time. Now, more and more companies are looking at this term good on time. What is good on time? Good on time is defined as time where the medicine works great for your motor symptoms without causing bothersome dyskinesias. Okay, now the way I said that, you can have some dyskinesias, and some people did, but as long as they weren't troublesome or bothersome, it's still considered good on time. Because listen, with any medicine, we can ramp up your dopamine levels sky high, control your motor symptoms, but you could be dancing all over the place because you have severe dyskinesia. So that's not the goal. The goal is not to just increase the dopamine, it's really to get it to that therapeutic range so that you're really not seeing, again, any off time or any kind of bothersome dyskinesias. Now, kind of tell you what's going on here. This was a double-blind, placebo-controlled study, but in the beginning, everyone was on immediate-release carbidopa levodopa or Cinemat. Then they were all converted over to Crexont. Okay. Then there became the double-blind, placebo-controlled part where they were either brought back to IR or stayed on Crexont. And you can see that there's clearly a difference in good on time between the Crexont arm, which is the top arm, and the Cinemat arm, which is the bottom arm. Excuse me, I'm just getting over a cold here. And just to kind of illustrate here a little bit what this is showing, because it can be a little bit confusing, is that they did show that the Crexont offered 0.5 more 0.5 hours more good on time versus Crexont. So you might say to yourself, oh, just half an hour more of good on time. So what? Like, that's nothing, right? But if you look at the average frequency that people were taking Crexont versus, and they didn't know it was Crexont at the time, but Crexont versus the immediate release, they were taking 3 times a day versus 5 times. So they were taking less medicine, right? Less medicine, less often, and still achieving that extra half hour benefit of less or more good on time, right? So again, if you're taking medicines 5 times a day, and I say, hey, look, I have this medicine that not only can improve your good on time, but now you only have to take it 3 times a day on average. You know, for a lot of people, that offers a really good improvement in their quality of life. And this was just in the study. They were only allowed to give it as little as about every 6 to 12 hours. They couldn't really deviate too much from that. And so they're actually doing a phase 4 trial in the real world, looking at, well, what if we had more flexibility in our dosing with Crexont? Maybe we could do a lot better with the on time if we had more flexibility with the dosing adjustments. And so we're going to be a trial site for that at Christiana Care. I know a lot of other places are going to be a trial site looking at real world data for that. All right, next up, Vyalev. Vyalev was approved in October 2024. And it is a subcutaneous or SC infusion pump of carbidopa levodopa. Again, nothing new about this medicine insofar as it's just a different delivery system and formulation of carbidopa levodopa. This delivers carbidopa levodopa right underneath the skin 24 hours a day. Vylev is made by AbbVie, who's also makes Duopa. Now, Duopa, for those of you who don't know, it's also an infusion of carbidopa levodopa, but this actually happens directly into that area of the body, that small intestine jejunum that I showed you in the other. There's actually a tube that delivers it directly to that small intestine. So whereas Duopa does involve a procedure, it's an outpatient procedure. This is an infusional pump that doesn't involve really any procedure or time at the hospital. It's something that you actually do yourself at home. Now, when it originally came out in October, we really only could use it for commercial patients, and younger patients obviously are on commercial, not on Medicare. Uh, AbbVie is committed that patients who are in this kind of setting where they're younger and they're commercial, that they'll offer this medicine for 2 years for free. But now we're able to use it for Medicare. Now that it's been out some time, Medicare has put it into their ruling as far as trying to figure out how much they're going to cover. But this only happened recently. So I will tell you that I have 3 patients on this right now. They're all commercial patients or younger patients. They're doing really well with it, but have yet to really, I mean, we're starting the process of applying for it for Medicare patients. And so really the issue with cost is pending as far as what it's going to be. We hope that it's going to be actually very affordable, even though it's a new medicine, because it's going to go likely through Medicare Part B. And Part B covers devices and kind of therapeutics like that much better than the drug parts. And a lot of times brand name drugs are not that covered that well with the Medicare kind of supplemental plans or advantage plans. And so we're hoping, similar to Duopa, that the affordability factor is not going to be an issue. Right now, we're in the process of trying to get a lot of patients started or applied to get started with this medicine on Medicare. But again, the how much it's going to cost is still kind of a pending issue. So what was the data behind Vyalev? And so what they looked at again was good on time, so on time without troublesome dyskinesia. Okay, and it was compared to again just oral immediate release carbidopa levodopa, and you can see from the mean change from baseline, right? How many hours of good on time they had at baseline versus at 12 weeks was about almost 3 hours better with Violet than baseline, whereas the oral IR only optimized about an hour. So there was about 3 times the increase in good on time in Violet versus optimized IR. And if you've ever been in a study, they really optimize the oral regimen to really a detailed point, and because a lot of people don't necessarily get that level of care or that the level of attention when they're dealing with their doctor for oral IR. So these are the steps. Excuse me. These are the steps to kind of administer Vyalev. It's not actually that complicated, and I will tell you that AbbVie does a great job with having nurses come to your home and educate you way in advance educate you and your caregiver on how to do this. I've been telling patients, and they've been telling me that they get way more education than they will ever need with this. So obviously you need to make sure you have a clean area. There's a kind of syringe that goes within the actual pump. You draw up the actual medicine in the syringe, you close it in the pump, you kind of prime the tubing that comes out. You kind of place the cannula, it kind of clicks in, and what that does, it inserts a very small needle with a tube right underneath the skin. Many patients barely even feel anything when they kind of click it in, and then you connect the tubing, turn on the pump, and then you're good to go. It runs 24 hours a day. We do recommend changing the site of the cannula around your stomach, kind of in this kind of letter or number 8 kind of sideways or infinity kind of symbol, or X symbol. And every day to 3 days. They recommend kind of switching it around, keeping your stomach very clean. That helps to avoid infections or irritations to the skin or underneath. But this is kind of the 5 Ps that they talk about: plan, prepare, prime, place, and pump. Again, you get way more education than what I'm giving you right now, but this is the delivery method. This is kind of like the new insulin pumps that are delivered. This pump is a little bit bigger, but there's many ways to cover it or contain it on yourself and wear it around. But there's no really restrictions to using this pump besides getting it wet. But many times, especially if you go swimming, you can give yourself extra doses with this. Go swimming, put it back on without an issue, as long as you do it under kind of a couple hours of doing that. And even if it was a longer time, they have a loading kind of dose for this. So this is, this pump and the next pump I'm going to talk about. It's a really nice way to finely tune the delivery of levodopa, bypass the stomach, the GI system, which really causes a huge issue for absorption of any oral medicine, and deliver it straight to the brain through the blood system. And so, we're able to finely tune both this medicine and the next medicine to a point that we can really skirt that therapeutic window over the full day. And so this is delivered 24 hours. So the other subcutaneous pump that came out is called Anapgo. This is apomorphine subcutaneous pump. It was just approved a couple months ago in February. It is also a subcutaneous pump, but it infuses a different medicine called apomorphine. Now, apomorphine, you may remember, is also in the medicine Apokin, which is also produced by Supernus. And it is a rescue medicine. It's kind of a rescue pen. If your dopamine levels drop and you need to bring them up really quickly, whether you're at an event or late at night or whatever, this is a nice way to kind of rescue from a low dopamine level with Apokin. And so now this medicine can be delivered. Now this medicine is delivered over a 16-hour period. So during your waking hours of your day, you take it off at night. And it's a type of what we call dopamine agonist medicine. Now, it was just FDA approved. Don't have much experience with this because they haven't really rolled this out to the public just yet. They're about to do that kind of this month, next month. So, more to come. We'll show you the data in a slide. But as far as real world experience, I have to admit I do not have any with this yet. So again, same issues with Vylev. We don't really know that much as far as how much Medicare is going to cover it. Other insurances, the jury's still out with that. So what they did, again, similar time span over 12 weeks from baseline. They said they looked at less off time and more good on time compared to placebo. And so you can see that Anapgo provided 2.6 hours less of off time versus 0.9 hours less of off time with placebo. Placebo being kind of just regular immediate release carbidopa levodopa. And then more good on time, about 2.8 hours per day compared to 1.1 hours per day with placebo. So very similar results to the prior pump. Now, when I say that, there's of course never, ever, ever going to be comparison trials between medications. For the most part, there are some rare trials that do that, but so we can never say, one pump is better than the other or one medicine is better than the other. It's just comparing what their data showed for good on time, less off time, things like that. Similar kind of idea with the prior pump. This is medicine that's already drawn up, so you kind of snap it into the pump or to the motor of the pump. It's connected to tubing. You attach the cannula to yourself, connect the tubing, and that's pretty much it. And then you start the pump. Someone like myself for both pumps are the ones that are going to be, programming the pump over time. All right. So that was the 3 pumps that we had, or that was 3 medicines, I should say, sorry, that have come out. I'm going to talk about other therapeutics that have come out. So For those who don't know, adaptive DBS through Medtronic Precept device. So DBS is deep brain stimulation. We could do a whole uh, hour-long talk on this, and we do at our clinic, but not for here. So deep brain stimulation is kind of a pacemaker for the brain to help with different motor symptoms like tremor, mostly slowness and stiffness of movements, dyskinesias, maybe some other motor symptoms. It's adjustable device, controlled both sides of the body over time with input from someone like myself to the device through the pace, kind of the battery pack pacemaker. We can do that wirelessly. And with this new technology, Medtronic has come out. We can now sense the brain waves surrounding the electrode that's in your brain in a way to adjust the signaling for different types of symptoms, right? So usually it was, you're in my office, I change the settings, look at your symptoms. Do they get better? Good. We're heading in the right direction. Are they not getting better? Okay, we're not in the right spot, or we're not using the right settings. And it was kind of like a somewhat of a guessing strategy, right? Now we have a way to sense the brain waves surrounding the electrodes in order to say, hey, I think if we use this type of setting, because I'm seeing this brain wave, maybe we can really target the symptoms in a faster, more efficient way with less side effects, less visits, things like that. So, adaptive DBS or ADBS was recently approved in February 2025, way before we thought that they would be. It came out very quickly. Um, you know, it has very good data, and I'll show you the next slide for really, again, getting a more efficient programming session. Many times in the old days, we would say it may take up to 6 months, sometimes longer, to find the right setting for DBS, and this does it a lot faster and a lot less guessing. The visits are more efficient. They're less time consuming, um, and what this does is it utilizes the constant sensing of the brain waves to adjust the settings automatically. And so what this tends to do also is kind of save battery life also, because a lot of patient symptoms obviously go away or greatly decrease while they're in true sleep. And the brainwave sensing can sense that the symptoms are decreasing and decrease the settings of the DBS overnight, again, to save battery. And so you're not constantly sending this huge wave of electric stimulation all the time when you don't need it. We also think, although again, the jury is still out on a lot of these effects, but we think that by having a constant signaling strength sent to these area of your brain all the time, that it allows for your brain to adapt to it. And then the symptoms come back, and then we have to keep raising the settings over and over again, and and it gets kind of into a wild cycle like that. We think that by allowing it to adjust itself, that your brain doesn't get used to any one setting, and so you don't see that kind of um, adaptation of your brain to the settings that it breaks through with your symptoms. So, I think again, this technology is new. I think it needs to be improved. There's still questions on the different types of brain waves that we're seeing and their implications to different symptoms. I think in the optimal real world, not only do we need uh, better AI utilization with these brain waves to better understand them and to adapt to your symptoms, but also some kind of additional input. So, one of the things that I think would be great, and I know the companies are looking at this, would be, and we're going to talk about this actually, is to have some kind of external device like a smartwatch measuring tremor or dyskinesia and sending that signal to the brain too, saying like, hey, look, I know you're seeing this brain wave and I know you think you need to increase it, but you're increasing it and the tremor is remaining the same, right? So that kind of external feedback of saying, like, the brain waves are not everything, right? The peaks are not everything. Is there other kind of data input that we can, create so that the DBS programming learns better? Because listen, we all love programming from a movement disorder perspective, but if we can save you time and visits by allowing this device to kind of work on its own and learn from your own physiology and your own brain waves and then adapt things and kind of change settings on its own, that would be the game changer. That would be the end stage, because then yes, there would be some input from us, but we would we would allow AI to really do its job and adapt to your symptoms and your brain waves. This is kind of just what a brainwave report looks like, just to give you a sense of that, with different peaks of beta and beta, gamma, and telling us different information about your symptoms between different electrodes. And again, just kind of data that we've seen so far, we do see that again, there's 85% faster initial programming that we do, which translates to less than 20 minutes of the initial kind of monopolar review, where sometimes that took a lot longer, sometimes up to an hour or more. Um, and this was 20 minutes less than the typical average, I should say. And then at least comparable clinical outcomes, although obviously the goal and what we have seen in early studies is that outcomes can be even better with this technology. And then finally, remote RPM is remote patient monitoring with wearables. So this is kind of I think, the next wave in tracking Parkinson's disease. This has been a few years coming of development and getting, good um, software and hardware for this. And so, we are partnering with a group called NeuroRPM. There are a few companies out there that offer kind of wearables in the Parkinson's world. They're all pretty much smartwatches that have these accelerometers in the watch already. So NeuroRPM utilizes Apple technology. They're looking to expand that to other big main brands as far as smartwatch technologies go. But a lot of these smartwatches have this already hardware built into it, where with the right software programs, and NeuroRPM does have FDA approval with their specific software, which has been shown to be reliable in picking out tremor, slowness of movements or bradykinesia, and dyskinesia. And so they can really track your symptoms on an everyday, second to second basis, and really create a smart report at the end of the month or in real time on how you're doing and send to your doctor, which is a great way to really monitor, again, how well you're doing, not only with your symptoms, how well you're doing with your medication adherence. You can see there's a really quick, easy button saying, I just took my meds. So we can see how when you take your meds affects your symptoms. Because I will tell you, whether or not you're talking to someone like myself, of any age, whether they have Parkinson's or not, our recall biases just are awful, especially when it comes to medications and symptoms. Yes, we have understandings of our bodies and understandings of how things are going, but walking through, like, well, how was last week compared to 2 weeks ago, and what about noon to 3 versus 4 to 5? Yeah, some of us have clear off time. Some of you, I should say, who have Parkinson's, have clear off time saying, I know when the medicine doesn't work. It's very obvious, and I know it can tell you the times. Many other people have vague notions. Yeah, I don't know. The medicine works sometimes, doesn't work. I have good and bad days. I don't know why they happen. I have good and bad times. They're kind of random, right? All of that is there is a pattern, and we're just trying to better figure out the pattern. This helps us in a more objective way figure out what that pattern is, so we can really go, you know what, I looked at this and I realized this time of day when you're a little bit late with your medicine, you really have this symptom, or the medicine's really wearing off overnight. We can see, all these kind of things. So we can see your sleep patterns, everything. And this really nice reports that we get sent to us, we can review, and then it actually can notify us when things go crazy, right? And yes, you typically try and reach out to your doctor too. But what if you have a span of a few days where you're falling all over the place, or your tremor is out of control? Something is going on, and that's a kind of deviation from what you're used to. This is when we can really kind of act in real time and see what's going on to be able to better take care of you. Now, there is insurance coverage for this. It's kind of complicated with the different kind of billing strategies for this, because obviously this is time that we use to review your data and things like that, and obviously getting the device and getting the software. But it is nowadays pretty well covered through Medicare and other insurances. So again, this idea where, even at a visit, let's say we're doing a medication change. I know what your data looked like before. Now we're going to look at data afterwards without you needing to say, well, I guess my tremors are a little bit better, or my wife says that I'm walking a little bit faster, or now we can actually say more objectively, no, you're much better. And it's funny because a lot of patients will say, you know what, I don't think anything changed from this medication. And hey, from a movement disorder perspective, if we hear that, we're not okay with that, right? With our meds, you need to see what they're doing and in a really obvious way. And so when we hear that, sometimes we'll say, "Oh, okay, the medicine wasn't really helpful. Let's come off that medicine, try something else." We'll come off it, and they didn't even realize, like, "Oh my gosh, I guess I was good because I feel so much worse off that medicine." Now we're able to better kind of remove that recall bias issue again that all of us have and get to the sense of objectively, are you doing better or not? Now, of course, there will always be times when I think patients will disagree, but at least we have more of the data of showing that. I was talking about this one patient case who's using this right now, and she's very sophisticated patient. She's younger. She's actually doing pretty well. She has DBS, but she also is taking medications, right? And I looked at her report and I found out she was only taking the carbidopa levodopa like 40% of the time, 40% of the time. And I talked to her about it and she's like, yeah, I try to take it. I forget a lot and then I don't realize it and then I move on. And it was like an intervention moment. She was still doing well, but it was something that I had no idea about, and she was embarrassed to tell me and stuff like that. So I think this helps in a lot of ways, and I think it helps just give us a better biomarker to follow you versus a one-time appointment every 9 months examining you for a half an hour or less for 5 minutes and then saying, oh, you look okay to me, right? Where we know that we're only seeing a snapshot of you. Why not take the whole picture of how you're doing from a physical perspective day in and day out, and then really adjust the way we're caring for you. So I'm almost done, and we'll have hopefully plenty of time for questions. But I do want to point out that we're still early in 2025. There's a few things that could still come out this year. One of them is another subcutaneous pump of carbidopa levodopa. We'll see what happens and how it will be different from the other current VIALEV pump. It's called Neuroderm. There's a really nice group of medicines called the D1, excuse me, the D1 D5 selective dopamine agonist. Now, as I mentioned before, dopamine agonists exist currently, but right now they're not selective to D1, D5. Why is this important? This is important because there are, again, 5 different types of dopamine receptors, and the other receptors cause a lot of side effects that people on dopamine agonists really don't like. It's not everyone who is on dopamine agonists, but a lot of people who are on dopamine agonists can develop issues with sleepiness during the day, with impulse control disorder issues where they become really impulsive, gamble a lot, shop a lot, binge eat, things like that, weight gain issues, sometimes hallucinations. So, where if we target the D1 and 5 receptors only, we can get the motor benefit of dopamine agonists, which is very good. They're very good medicines for that, without all the dirty side effects of what I just mentioned. And so, this is kind of going to be a next wave, probably of 2 to 3 medicines, they look very promising. Hopefully, we're looking at end of this year, maybe 2026 before they come out. But a great option because dopamine agonists we kind of cut off after the age of 70 because the risk factors go way up after that. These types of medicines, these types of selective agonists, look to be much safer to the point where we can use them in older people. And then lastly, for those who don't know, focused ultrasound is it's called the MRI guided focused ultrasound. It's a way to treat right now tremors in Parkinson's disease. It uses 1,000 ultrasound waves directed at the tremor center of your brain. When they all intersect at that area, heats up that area, creates a ablation or essentially kills the cells that are causing the tremors. There's going to be most likely a new target later this year targeting other symptoms of Parkinson's with this technology. It's an outpatient procedure and very kind of highly, there's a lot of interest in this types of outpatient minimally invasive procedure, especially for older patients. All right, so thank you for listening. And Judy, I think we're ready for questions.
Okay, first question. Are there any new medications or medication delivery methods with fewer dyskinesia side effects?
Um, so the whole goal for all those medicines that I mentioned is that there will be less dyskinesia, right? The whole goal of good on time is less off time, but also less dyskinesia, right? And so all of the three medicines that I mentioned today do actually offer that by allowing us to kind of skirt that therapeutic window without getting too high. So in essence, that's part of the answer. The other part is, at this point, there's really only one medicine that's approved to treat both off time and dyskinesias, and that's Gocovri or the long acting amantadine. Amantadine and long acting amantadine Gocovri are really the only medicines directed specifically at dyskinesias, but a lot of the other medicines allow a decrease in the risk of dyskinesias by lessening this kind of really high peaks and valleys of the dopamine levels throughout the day.
What long-term planning options do people have? I've tried to get loft insurance, but I'm learning that companies don't want to cover me. I'm wondering what I should and could be doing to prepare for the future.
Ugh, that I would say that's a better question for there's a lot of long-term care plans out there. I think it is always better, obviously, to get it if you can earlier. I know it's cheaper, but that's probably more for either financial planning or legal to answer or social work. They're more experienced with that.
My symptoms, as my medication is wearing down, are not only the facial stiffness, but nasal congestion and shortness of breath. Is this something that you have heard other patients mentioned, or do you think it's unrelated to my Parkinson's?
Yeah, I mean, we always get concerned when we hear about shortness of breath being an issue, and we always want to rule out cardiac and pulmonary issues. But many patients do have what we call non-motor symptoms to the medicine wearing off, and a lot of patients get severe anxiety, waves of depression, fatigue, and so that is something that we pay attention to. So it's not just your motor symptoms that tell you that the dopamine is wearing off. Many times it is non-motor features, and so that is something that does happen.
Okay, next one. When do you suggest starting medications versus more conservative treatments?
So, again, I'm always about conservative treatments. I'm a big fan of exercise, obviously, in general, physical therapy, occupational therapy, speech therapy. There's good data for acupuncture. There's good data for massage. A lot of those things you have to keep up with. A lot of those things insurance doesn't cover. And that doesn't truly get to what's going on physiologically with the disease, right? So the underlying issue is your brain is not making dopamine anymore. And it's very hard to drive that production in other ways, at least that we know of. And it's not even as simple as exercise, because even though, yes, exercise will slow down your progression, we do know that it's not exercise necessarily that increases dopamine. That you in life you have like 50-50 people, the types of people with Parkinson's, where half of them will say when they exercise, they feel like they need less medicine, that they can go without any medicine, that they feel great. The other half will still say, "Hey, I feel good with exercise, but I actually need a little bit of bump of my medicine before I exercise to get me through the exercise." So again, it's not even as easy as like, oh, just exercise and raise my dopamine levels. It's not that easy. Again, if you think about it like a vitamin, there are a few people out there that would make this argument for other things, right? Yes, it's a medicine. I know that that's the caveat, but you won't see many people saying in life, like, again, oh, my vitamin C levels are down. I'll just try to exercise and get them up, right? It's a no-brainer. Be like, I'll take a vitamin C, or I'll take a B complex, or I'll take B12. Plenty of doctors check lots of different levels of these different vitamins and other kind of electrolytes. And again, you don't just kind of wish it away or try other things, you're like, oh, that's easy. I'm just going to take a supplement and kind of fix it. I think it's that medicine connotation that this gets a bad rap. But again, this is the cleanest, most direct medicine that you'll ever take, and that's why it's something that has still been the best medicine since the 1970s, right? And the safest, especially for older patients.
Okay. Has the pouch-like item been approved by the CDC? If not, what are the issues that need to be addressed?
You said patch,
Pouch, Pouch.
pouch. Ooh, I don't know of any pouch medicine. Um, I do not know that answer.
Okay, so if the person who asked that question is on, maybe you could try and clarify that a little bit in the chat.
And I always tell patients, hey, send me articles, send me news articles. I had two today send me the same thing about like ilobuphane or something like that. It's crazy what is out there. But hey, I will always look at the articles because, and you can always tell. This article specifically, or this compound, when you go to the website, and you should always do this. Whenever they talk about Parkinson's, they're like, "Oh, this was really effective," and this website did that in animal models. Whenever they say
Yeah.
that, that's great, right? And that means there's promising studies that could come from that, but you never want to go from animal models to humans, right? Or at least assuming that it's going to be
So
helpful, right? So
I
that's
think
the
so.
first thing. And then the other warning sign, which this website also had, was there was no link to even the animal studies, right? Because what
Mm,
what are you trying to hide? If they're animal studies, they're out there. They're everyone should be able to look it up, right? If you don't even include the link, even at the bottom of the page or anywhere referencing that, that's also a warning sign that it's kind of probably shady data.
little shaky there. What treatment is available to help patients with Parkinson's improve cognitive decline and memory loss issues?
So the big medicines that help with cognitive decline are usually, in this order, is usually the way we prescribe it: rivastigmine or Exelon patch, donepezil or Aricept used to be called, memantine or Namenda it used to be called. There's one galantamine, but it's kind of less used, less studied. Those are the main ones. They're not very effective. They only work about a third of the time in Parkinson's as a whole, so it's not that successful of the medicine, but at least it does better than other things, which, if we get more desperate and we reach out to some supplements like um Prevagens of the world and things like that, but even they don't really have really good data behind them either. So
Um, I gotta take my glasses off. Is there a volunteer study that I could join on stem cell therapy?
oh, I mean, they're always, by they, I mean the community of Parkinson's researchers are always doing studies on stem cells and Parkinson's. The whole question is, who's recruiting, where are they, right? So at least I'm more familiar with, the Baltimore, Delaware, Philly area. I'm not aware of anyone in this region doing that. Um, so again, it's more just about a transportation issue, if anything, getting there, and then finding out, talking to your doctor, your neurologist about what, sending him the specific trial if you do find one. Say, hey, what do you think about this for me? Do you think I'd be a good candidate? Tell me more about this, because a lot of times we're able to decipher the jargon of studies, and I usually tell patients, go the best place to go to is clinicaltrials.gov. It's one of the good government websites, but you can actually search by your disease, Parkinson's disease. You can search by region. You can search by if they're recruiting or not. And then you should look through, you can search by stem cells. And then you can find out who's offering these. Send that information to your neurologist to review. And then he or she can tell you if that's a good idea or not. So.
Okay, next. I have started a long-acting Sinemet regime, but it doesn't seem to be helping. How effective is this supposed to be overall?
Yeah, I mean, again, depending on which long acting you're talking about, we do expect that it should work at least a half hour to an hour longer than the current carbidopa levodopa immediate release, right? Now, some people, and again, it depends on, and this would probably be better for individual question for neurologists or for their neurologist, but let's just say you're on Rytari, right? And you're taking it 4 times a day, every 4 hours, and you're like, I'm still getting like an hour of off time, right? It may be that because you're still getting that hour off time and you go to something like Crexont, you may have to maintain the same schedule, but you don't get that off time, right? So it's not always the case where you can go to a long acting, decrease the number of times you're getting, and get more off or less off time. As I mentioned before, it's hard to get a really dramatic impact of both. Sometimes it's about talking with your doctor. What are the goals? If the goals is like, I want to take less medications less often during the day, what do I need to do for that? That's a different question than I don't mind taking 4 times a day, but I'm having a lot of off time that I'd rather not have. How can I handle that? So it's a little bit nuanced of an answer.
And I'm wondering about high dose thiamine therapy.
Um, so there are very small studies looking at thiamine therapy for Parkinson's. Right now, it is not enough to really suggest it or offer it to the majority of patients. Thiamine is usually something that we give actually to alcoholics because they don't tend to get a lot of thiamine in their diet, and the alcohol doesn't allow it to be absorbed that well. And so, but in the case of Parkinson's, right now, I think it's more in research than it is something that we actively recommend.
Depression in Parkinson's. Do you have any drug suggestions?
Yeah, I mean, the good news about depression and anxiety when we're treating that in Parkinson's is that there are so many options, and so many of them are safe to use in Parkinson's. I know there are no guidelines behind this. There are certain data that can give us certain types that are more studied in Parkinson's, but I will tell you, it really just tells us about the families more than the individual drugs, because all of us in this community have used probably all of the different types of depression meds and anxiety meds and get different successes out of them. It's all based off what we are worried about, side effects with the patient. Um, Different patient factors are important to them, like number of times a day, how it works, how long it takes to work. There are other medications that they're on. So, unfortunately, I'm not going to give you a specific answer to this because it really, really depends. But hey, again, the takeaway is the good news is that there are a lot of options out there, and it is something that people get frustrated with, unfortunately, that, hey, there's a lot of options. That's great. I'm not, I won't run out. You will not run out of options for the most part, but people do get frustrated because it is trial and error. It really is. There is no test we have right now. I know there's some genetic markers with psych meds, but for the most part, in Parkinson's, with depression meds and with anxiety meds, there is no way to say this one will work great with you with no side effects. But that's our goal, to be honest with you, when we're talking about this, because we have so many different options. I'm going to find something that works well with your depression or anxiety and does not give you any side effects or minimal, middle, tiny, tiny, maybe side effects, right? Like the benefits have to way outweigh the risk if we're going to be using a med because we're not desperate for anyone.
Hey, oops. Um, all right. Oh, here we go. After 2 years of unknown symptoms, my mother has just been told by her family doctor to get checked by a neurologist for Parkinson's. My mom has been to a neurologist before, but now we're being told that the person she saw was a sports medicine neurologist, and that's why they didn't check her for Parkinson's previously. Which means that we're now on the hunt for a new neurologist, specifically an expert in Parkinson's. I want my mother to have the best care with a doctor who is open to both medical and alternative treatments. What questions do we need to ask? What do we need to look for to ensure that she's working with a reputable neurologist in the Maryland, DC area? And then the person says, do you have any recommendations?
Yeah, so obviously you want to find a movement disorder specialist like myself. There is definitely, I mean, there's a reason why we exist. There's a reason why there's a fellowship for this. There's a lot of information about Parkinson's, diagnosing it, picking it up. treatment options for it, especially nowadays, advanced treatment options that we can provide. And it is within the guidelines that you should be seeing a movement disorder doctor at least once a year for your Parkinson's care, understanding that there are plenty of places in the country or even within our region that it's just hard to get in. And so we do recognize that a lot of patients are being cared for by a general neurologist or even their primary doctor. Goal is to try and get in at some point with a movement specialist. And, you know, the movement disorder community is a small community. Unfortunately, I wish there were more of us that we could see patients with. With that comes a very tight knit community. There's a quarterly movement dinner where everyone from DC, Georgetown, NIH, GW, all the community movement doctors, Baltimore, Hopkins, University of Maryland, and then I come from Delaware. All come for a quarterly dinner meeting. We share cases, we share research with each other. It's a really kind of amazing event. But I say that only to say that I know everyone in the the tri-state area, DC, most of Northern Virginia people and Maryland. And I will say that you if you find a movement store to doctor to see here, you pretty much can't go wrong. I mean, they're all really, really good, smart people here. Obviously, I do know everyone, so I mean, but I would go to any of these people. We lucked out. We're in a very good region for this, and so I know Judy has worked with tons of them. She can tell you that they're all really good too.
Mhm.
And so I think it just and as far as asking the right questions, you ask the right question in the question, meaning, okay, so you talk to the doctor, get a good sense that he or she thinks you have Parkinson's, and what are you going to do to confirm that? What are the options? Just like you said, hey, doc, what are the options? Okay, those are great. And if they just spit out meds, right? Okay, those are great meds. What about, do you ever consider alternative options, complementary medicine options? And then they'll tell you, right? And so um, I can't necessarily comment on that from each doctor specifically, but I think we all kind of know there's always going to be a role for medicine based off dopamine levels, but at the same time, that doesn't take away from the possibility of these other options helping out your dopamine, helping out the medicine.
Are there any new medications in development?
A million, like I said, it's amazing. It's great that we there are so many things right now being developed. Again, it's Parkinson's, it's Alzheimer's, which is obviously very prevalent in the United States, and then Parkinson's is second as far as neurological diseases receiving research money. So I'm not, it's more a matter of time than it is what are they going to be or how many they're going to be.
Is there any research on vibration therapy? This topic was presented on NBC's Today Show a few years ago.
Yep, it was the vibration glove, and that was out of Stanford, and they are still working on it. I'm always cautiously optimistic about wearable technologies for therapeutics, whether or not you're talking about a glove. There's a vibration shoe that's still being developed, especially to help with freezing of gait or the kind of hesitation in your legs, but other symptoms too. And we do know this principle from like the 18th century or 19th century, where people would take long trains across specifically India, and at the end of their train ride, and it was very bumpy, right, in the country, their Parkinson's symptoms would be like dramatically better, right? And so there was this idea of vibration with treatment of Parkinson's. So this has been known for like a very long time. We are trying to perfect it, obviously, and get it to being very effective as a regular treatment that's not a dramatic treatment and can be tolerated. So we'll see. I think some of these therapeutics devices have unfortunately not been as promising when it comes to the end of studies as we hope for. But that doesn't take away from still our, again, being cautiously optimistic about this.
What is adaptive DBS?
Oh, you weren't listening, or I didn't make myself. Well, was that one of the pre-submitted questions?
Mm-hmm.
Oh, well, I
Yeah,
answered it then. That's okay. I answered
yeah.
it.
Um, can PD eventually cause pain all over your body? And can you do anything to help with the constipation?
So pain is not necessarily that common of an issue. It's more of an indirect issue, meaning if you have a lot of stiffness in your muscles from Parkinson's disease, and you have a lot of arthritis in your joints, that kind of stiffness will put a lot of pressure on your joints, contributing to worsening of that pain. But it's usually not like pain from Parkinson's, like pain can be from cancer, right? It's usually something underlying that the Parkinson's is worsening. And yeah, many times we can give more dopamine medicine, sometimes other types of medicines to help with the pain. So that's kind of something you're going to talk with your neurologist about. Sometimes it's about looking at other things first with your primary doctor, making sure there's no other causes, because that's one of those things. Trust me, when you talk to a movement doctor, we'll tell you all the time, yep, that's Parkinson's. Yep, that's Parkinson's. Yep. Pain is one of those funny things where it's like, we probably should rule this out for other things first before we just kind of wave it away and assume, oh, it's from Parkinson's, right? So sometimes it is obvious that it is, but it's rarely the case. Constipation, a lot of things to talk about. Exercise, hydration, super important with constipation. Many times, unfortunately, people do need over-the-counter supplements every day, not just as needed. Like every day, usually we start with the stool softeners like Colace or Docusate. Same thing, Senna, and starting one tab, gradually increasing it as much as two twice a day for both. Some people need to be on both, and every day, no matter what's going on, to really keep your bowel regimen consistent.
Um, okay, next one. Is it possible to stay even with Parkinson's symptoms? I'm sorry. Is it possible to stay even with Parkinson's symptoms with a heavy exercise schedule?
People have very different levels of progression for sure. There are many people who are on the better end of the spectrum, sometimes even despite exercise, that progress in a very, very, very slow rate. There are many other people who exercise is everything and it is dramatic. Like I can always tell if you've been exercising or if you haven't. It is that because, yeah, everyone knows, right? Exercise is good for you. Everyone talks about that, runner's high and feeling good with exercise, and all that is still true. But in Parkinson's, it's like times 10, right? It's like I feel, again, a lot of people say I feel like I'm on medicine. Like I feel like a new person when I exercise. And so it is that dramatic. And again, it is the only thing that will slow the progression. So yes, I will say that it is a good hope that you can get to very slow progression if you maintain a good exercise routine. And we talk about that usually being somewhere between 30 to 45 minutes a day, sometimes an hour a day, and then doing small things throughout the day too, right? Because you're not doing yourself any favors going to the gym or doing an exercise routine at home for an hour and then sitting for 10 hours watching TV, right? So you do want to break up your day. Yes, it's okay to watch TV, read, work on the computer, but you got to break up your day with small little chores or laps around the house or whatever.
Are there any treatments on the horizon for balance and slowness, specifically in Parkinson's?
Well, slowness is all the medicines. They're all supposed to be treating that part, but balance, you know, uh, unfortunately, I always joke that there's no pill for balance, and there's a reason for that. Balance is controlled by several different systems of your body: vision, hearing, your inner ear, your vestibular system, your cerebellum, your what we call proprioception, which is kind of the nerve endings in your hands and in your feet that tell your brain, especially when you close your eyes, where your limbs are in space. That's your proprioception. Strength. Um, I can go on, and unfortunately, there are so many different systems that control balance that there is no there will not I never say never, but there will like never be a medicine for balance because again, if you start knocking them out, and that happens with age, obviously, right? Your vision gets worse because of whatever cataracts or glaucoma or macular degeneration or whatever, and then that starts getting out. Then you start developing issues with neuropathy because of the Parkinson's, and so that defeats the proprioception part of things. And then you develop tinnitus or ear ringing or some kind of inner ear issue because you're having all these sinus infections, and then you develop just brain atrophy in your brain and your cerebellum. So again, all these different things start happening, and your balance gets worse, right? You develop spinal issues, arthritis issues, joint issues. Um, but because we know all that and how it plays a role in your balance, that's what we tackle, right? And yes, some people are lucky enough where the dopamine levels in their system improve their balance. Some people are like that, and great. But that's not most people. A lot of times they'll say, like, I don't understand. I increased my med, and yeah, my tremor went away, but my balance still, is awful. It's not for balance, right? There's other ways that we can tackle your balance by addressing some of these other issues.
Okay, this is the last question that I've got. What are the best medications for anxiety with Parkinson's, and what are the best medications for sleeping?
Well, I kind of answered the question about anxiety before with depression, but as far as sleeping goes, usually we start. So, yes, it's always important when we're talking about sleep to maintain a good sleep hygiene, right? Turning off any kind of activity or things that activate your brain, whether that's TV, computer, laptop, iPhone, whatever. you know, the studies are actually pretty aggressive. They're like, at least 3 hours before bedtime. I don't know how realistic that is nowadays. To not eat or drink late at night, not drink alcohol late at night, like all these different things. And they're not for everyone, right? Some people, we never recommend this, but some people are like, what are you talking about? Like I, have a glass of wine every night and I go to sleep great and I sleep great. So it's not for everyone, but some of the things we talk about. And then after that, because sleep is very common of a problem in Parkinson's, sometimes we'll recommend getting a workup for sleep apnea because that impairs a lot of people with Parkinson's, their sleep quality, especially if you're snoring a lot at night or you have apneic episodes where you stop breathing. Your spouse or someone you're sleeping next to would know that. Um, and then after that, the first recommendation is usually melatonin. Every night you have to take it every night. Usually you start with 3 to 5 milligrams, increasing it every week by 3 to 5 milligrams, a maximum of 15 milligrams. Again, every night you got to take it no matter what's going on because you don't know if you're going to sleep well or not. Take it every night. We think that Parkinson's patients tend to have a lower melatonin level in their brain as it is, which is why this helps. That's the best conservative kind of over the counter option. And then after that, the best medicine that's been studied the most with sleeping issues and Parkinson's is a medicine called clonazepam or Klonopin. That tends to be the next best medicine. There's plenty of other medicines after that, but that is kind of the algorithm, at least at the beginning.
Well, that was the last question that was submitted, and I don't see anything in the
Yeah,
chat, I
I've
don't think. No,
I've
I
got
don't.
Alexander raised his hand, and I could allow that person to talk if they take their device off of mute.
Alexander, are you still there? Did he ask the question?
No, just raised his hand.
Yoo-hoo.
He may have left. Yeah.
Yeah, yeah. Well, if anybody wants to ask a question, feel free to, you can just email me, and I'll forward the question to Dr. Martello and we'll put the email, Michael, let's put the email in the evaluations that we're gonna send out. Okay,
Okay.
so we'll send out the evaluations and we'll put my email in there. And if you have any other questions, just feel free to email me. And then I'll ask Dr. Martello and get back to you.
All right.
Okay,
Thanks, everyone.
thank you. I'll see you. I'm gonna see you shortly. You're doing something for somebody else with us.
That's
I don't
right.
know who, I can't remember who.
I will see you guys soon.
Okay, thank you.
Bye.
Thanks. Bye.